Aloha, welcome everyone. Thanks for taking the time to come and be part of what I think is going to be a fabulous panel discussion talking about behavioral health and integrated care systems and kind of crisis management and some updates in regards to where we're at here on Hawaii Island. My name is Tim Hansen, and I'll be facilitating or moderating or trying to control this group of panelists, which I'm so appreciative of them being willing to dedicate their time and to share their mana'o with us. I am executive assistant to your Mayor Mitch Raw, and it's been such an honor being able to serve with Mitch and moving forward on his passion around mental health issues and concerns here on our island. He's given me a lot of freedom to be able to venture into this world of trying to make changes to better our mental health responses here on the island, also looking at detox and treatment programs. And then I also get to dabble with peace and conflict resolution things, all good things about wellness and well-being here on our island. I'm a clinical licensed social worker. I teach at UH Hilo, graduate of Manoa's MSW program, which I highly recommend. And my passion for this work in this area, I won't go through the long story, but really started in the 80s, in the late 80s. Can't believe I've been in the work this long, but it's wonderful. But my passion over the last few years in regards to mental health and crisis response services here on the island have been sparked by a number of different things. But before I go into that, let me just say that I'm blessed enough from my house in Hilo, that I get to stand on my lanai and I can see the ocean in the distance, a little peekaboo view, but it directly faces east and the sun rises right there for me. So it is always my goal, and most mornings I'm successful to be out there, being able to watch the sunrise. And even this morning when it was quite cloudy, still there was just enough of a break there to see that break of the new day, breaking in and chanting Eala E and just welcoming the day. Gives me chicken skin just to remember. And I always offer myself as an instrument, a grounded instrument of peace, hope, and love. And that's how I choose to navigate throughout my day. And that's about showing up. And you've all shown up for this, so if you can just take a moment to tell one another next to you, thank you for being here, thank you for showing up. What sort of propelled me into this realm in the last 2.5, 3 years was really around the tragic death of Carla and Jeff Takamine. And I was so inspired this morning to go to the table, and you all saw these, right? You know where these cookies are from? And who was the business owner of Big Island Delight? The Takamines. Carla Takamine. And so when I saw that, I was like, thank you, Carla, for being here. Mm-hmm. And it was her tragic death, her and her husband Jeff's tragic death, that really highlighted the gaps in our services here on the island when it comes to mental health. So their grandson, Joshua, struggles with a severe mental illness. And I know that there's lots of different variables that can happen within someone's life. But if I think about if Joshua was to show up at the emergency room and his arm was almost completely severed, it was just hanging by a few tendons. It was disconnected from him. He wouldn't have just been sent home because there wasn't someplace else for him to go, or that place was filled, or whatever it might be. They wouldn't have just said, "Oh, just try to hang on to that arm, go on back home." But the reality is that for Joshua, his brain was disconnected. He was barely hanging on to reality in a number of different ways. His grandparents had taken him in, and the family to love and to care and try to support him. And when he was discharged from the emergency room and not another place to go, he went home. And unfortunately, during the night, in delusion, thinking, disconnected from reality, he grabs a butcher knife and he stabs his grandparents to death in their bed. Right? 2.5 years ago in Hilo. His brother and sister tried to intervene. They're also stabbed and injured. Not in a life-threatening way. They were able to contain him until the police were able to arrive. Carl was a very good friend of Mayor Mitch Roth. And when he got the call about Carla and Jeff's death, he was pretty devastated. And thought, what in the hell is happening in our community that could happen? Right? And what is happening in our community when someone kills the very people that love and care and want to support them? What happens in our community when someone kills a stranger because they believe that they're a demon or an agent or someone sent from somewhere? What's happening in our community when someone kills themselves because they cannot access the services that they need or they're not able to function? What's happening in our community when a woman can give birth on the street in Hilo, not even knowing or recognizing that she was pregnant? So these are the things that wake me up in the middle of the night and remind me that I need to show up and I need to try to figure out and help our community to get better in regards to how we're going to provide the services that we need to care and support and to love one. Carla's brothers, Wayne and Michael, contacted the mayor's office shortly after Carla and Jeff's death, and they said, especially Michael, who's a mental health professional in California, said, we are really concerned about our home community, and we want to be part of something that can get things sort of moving forward, so that, my God, nothing like this ever has to happen to another family. And so with their help and with the incredible partnership of NAMI, we put together a mental health summit. And from that, we began to look at the continuum of care that's needed in order to better serve our community. A reimagining of crisis response that includes always having someone to call, like our 988 number. Always having someone to respond, a team of people. And if it's the police, to make sure that they're trained in crisis intervention techniques so that it's a positive encounter and not a negative encounter. That there's always some place or places for people to go when they're in that crisis situation and to help them stabilize and transition back home or back into the community. And finally, that there's always someone to support us in our own mental health journeys, keeping ourselves healthy, connected, and contributing to the community. So, and I've added one, which is someone to fund us, because we need money to make kind of all of this stuff work together. So we formed 4 groups. We did some really wonderful work, and then this last September, last month, we held a second summit, and at that summit, we specifically focused in on having some place to go, because there's not sufficient places, a continuum of care or crisis care in regards to places to go. And so we are also getting ready for the county to fund a community-based mental health crisis center. Our goal is by the end of December to have a provider contracted and in place, and for that crisis center to open up sometime in early 2025. It'll be in town in Hilo, and it will include an observation, a stabilization unit where folks can stay 23 hours, 59 minutes, so it's not a residential, so we just call it 2359. But it'll also be a very integrated health clinic, because like the slides this morning, we need to think about the entire person, not just a piece, right? So our physical health is connected to our spiritual health, our mental health, our communal health. And so how do we really go back to remembering that and serving people in that sort of way? And that's a lot of what we're going to spend time talking about in our panel. Susan encouraged me to take more than a little bit of time. That's always a danger because I love to talk and get moving on this stuff. And when my blood gets moving, especially, I'm getting track of time. But the other thing I wanted to highlight is how many of you are aware of the 1996 Health Parity Act? Health Parity. Wow. So in 1996, the Mental Health Parity Act was passed. And it was a law that established parity in health insurance coverage for mental health and medical and surgical benefits. The law required that health plans have mental health benefits and not impose a less favorable annual or lifetime dollar limit on those mental health services. 1996, a law that says we need to pay attention to mental health as well as physical health. That health means health for the whole person. And we're coming up on 30 years. And we're making small strides forward in regards to that, meeting that goal. And again, it's kind of like going forward to meeting that goal. But if we could remember by looking past, that's probably more how we took care of each other several generations ago, a few hundred years ago. We figured out together how to make sure that we were okay. Enough said for me. I'm going to let our panel introduce themselves, and then Dr. May is going to do a short presentation on integrated healthcare systems, and then I'll invite the panel to do some reflections on that presentation, and then we'll open it up to questions and comments from you all as well. And then we'll see where we're at that point, and we'll wrap up at 2:45 because that's what you said. Are we good to go with that?
Yeah.
All right.
Can you tell me when to get the cookies?
Oh, the cookies. Sorry, yeah. Maybe later. So I want to start on this end. If you could please introduce yourself and say a few words, and thank you for being here.
Absolutely, like you're a tough act to follow. I don't know that after that impassioned introduction of yourself. I'll do my best. I want to thank all of you also for being here, and I am so blessed to be part of this panel and to wake up this morning and welcome the stage. I'm here with my dog, Paul Malavia. He is an integral part of my team at Hope Services Hawai'i, where I serve as the Director of Health Services and a clinical nurse practitioner. I started my career as a new grad registered nurse in a large Adventist hospital in Southern California. And it was the best introduction to healthcare I ever could have had. It was the most comprehensive education. I had the best mentors and preceptors who got me started understanding not just the medical process, but the human process. There was a lot of death and dying. And so we worked very closely as a team together with our medical doctors, but also with families, with the entire hospital. We were all part of a great team to care for people who were struggling with very serious illnesses and often ended up in end of life. I had one patient, I remember, that we quoted 5 times in 1 hour because the family wasn't ready to let go. So these things stuck with me, and I kept asking myself, how do we prevent this suffering? How do we mitigate this suffering? What's going on out there in the world that we are working with this, this level of need here in the hospital in this acute setting? My parents were born and raised on this island. My father's from Captain Cook, my mother's from Hilo. They retired here. And so I say, I was always meant to come back. I visited Hawaii so many times. I have a large extended family here, and I love it here. So I am OPD, even though my children live on the mainland. I'm not going anywhere anytime soon. And they love coming here, so that's a draw, right? But when I moved back here, understanding that there are these gaps in care. here on this island. And my father, when they first moved here, had to go to Oahu for an open heart surgery, a 3-vessel bypass. And I flew in and what is going on? Why did you have to come to Oahu? What's going on the Big Island? I don't understand. So I work with an organization that is visionary, innovative, under the direction of Brandy Menino. I'm sure most of you, if not all of you, know that name. And it's working with individuals experiencing homelessness in various stages of their life journey. But I appeal to you to understand and take a moment to think about yourselves, your neighbors, friends, family members who are just one step away from being in a position where they could be homeless for all kinds of reasons. You hear it in the news if you don't have a direct experience with it, that the cost of healthcare, we talked about it all morning, the cost of healthcare. It's just one catastrophic illness and a lack of a support system, and there you are. It takes changes in healthcare legislation. Medicare is making all kinds of changes right now. What does it mean? I don't know. I have to go talk to Medicare specialists. But on behalf of my parents, on behalf of some family members, because I don't understand all the changes that are happening. So it's not just about, here we are, we're okay, I woke up this morning, I'm so blessed. And then there are those people who need our help, those people who need our help. No, we're all in this together. We are all a community of how am I going to help people? How am I going to create a system that offers equitable services and access to care to everyone so that we can prevent these catastrophic illnesses if possible, right? We can only do so much. Or we can prevent that next step into homelessness, which, gosh, the Maui fires, right? Who knew? Or the lava flow that we had in 2018. Who knew, right? So there's so many unique journeys to homelessness. There's so many unique journeys to this high level of need. And mental health is both a cause and a consequence of our life experiences. Because we're talking about severe mental illness from being schizophrenia or bipolar, but we also have to consider depression, anxiety. So these are very much hidden sometimes, that people are suffering from all of the trauma in their lives. So when I came here, I became a charge nurse out of Pahoa, in a primary care clinic. What an education. My life is just all education. And I realized, wow, there are a lot of health inequities. So many. The gaps in the social determinants of health and the services that we provide. So I made it my quest. I'm going to figure this out, right? I'm going to make a difference. I'm going to try to do something. And I started taking grant work, right? Because follow the grant. Because the grant's going to be a pilot project, something innovative, something that we can, we're going to create something sustainable. That's a whole other story, and I could go on for hours about that, but education. What it led me to was, that's how I got into my graduate degree. Everything happens for a reason, right? So I pursued my graduate degree, and in all of this, that's also when I met and subsequently started to stalk Brandy Menino. And I said, Brandy, what do you think about bringing healthcare to the homeless? And she said, not yet, Angie. And I said, I didn't hear the no. I heard the not yet.
Yeah.
Ooh, door open. All right. And I stayed in touch with Brandy, and here we are today. And I think everything is meant to be. It was right time, right place. I'm privileged to be a part of this organization. And how are we integrating healthcare, treating the whole person? Well, because we provide shelter, which is a basic need. But we are also trained to think about what are all the traumatic events that led to this moment, because people don't wake up in the morning and say, I want to be homeless today. I want to have unmanaged medical and mental health conditions. I just want to, keep going in and out of the hospital or in and out of jail or in and out of prison. I want to alienate myself from my family. Nobody does that, right? So we recognize in a harm reduction, with a harm reduction methodology, to work with people, build relationships, gain trust, and offer services at the time when they need it without judgment. And Brandy and her brilliance built in funding. It took a long time. It looks like it just happened, but no, I know that was in process. I came on in January of 2025, or 23, but this has all been in the works. And I just, right place, right time, said, Brandy, I got any work for me? And she said, as a matter of fact, right? Medical respite, street medicine, shelter medicine. We now have codes that if I had 5 minutes with Judy Moore Peterson, like, could we just start getting that really rolling, okay? Reimbursement, because that's going to be, we've been hearing, that is the future of how we are going to create a sustainable system for healthcare. It needs to come to the people providing care, boots on the ground, okay, directly with the people who need it, understanding what they need. We're not cookie cutters. So, I'm rambling. Am I rambling? I need to set my timer. Oh, I did. Oh, I set it for 20 minutes.
No, that was wrong.
I set it for 3. Okay, so I'll stop because I know that we're going to continue, but that's who I am and where we're at right now.
Thank you.
My name is Jessica Stevens, born and raised in Nanakuli, graduated Nanakuli High School.
Yeah.
And I, too, like everybody else here, moved away in '99, moved to Las Vegas for a bigger, brighter future. Spent almost 20 years in Vegas, and there was an opportunity to come back to Hawaii in 2017, but the job was in Hilo. And so we were like, I'm not here, I'm going home. No matter where we're at, I'm going to be back in home. So we made that move back. But moving away allowed me to go back to school. I was able to work for the state of Nevada. I was able to work for the Department of Veterans Affairs. Worked on Nellis Air Force Base when it was a VA Air Force Venture Hospital, kind of like Tripler. And was part of the brand new opening of the new hospital in Vegas. If any of you go to Vegas, drive north, and you see a building that glows blue, that's the VA. You can see it in the city. But I've met some wonderful people along the way. I grew a lot in my career. I went back, got my master's from the University of Arizona, and came back to Hilo, worked for Adult Mental Health Division. I did all of their quality metrics for all of their outpatient clinics here in Hawaii, on Hawaii County, and worked with the other islands as well. And then COVID hit, and I thought, I don't know what's gonna happen. I'm in administration. Maybe I'll be the first one to get cut. I'm not sure. And just so happened, Hilo Medical at the time had this posting for nurse manager. And I thought, well, that might be a good fit. So I went there. And I've been there for the last 4 years. So honored to be there, watching the growth that's happening there. We're now Hilo Benioff Medical Center, and the expansion that's happening. But I can tell you, from an inpatient standpoint, going back to behavioral health, we are a 12-bed unit, which is really small when you think about the geographical size of the Big Island. And, it's super small, but what is amazing is that we are able to network with a lot of community partners, such as Hope Services. And I think we've partnered with them on medical respite beds, and that's really helpful. We work with Hawaii Cares. We use that 988 number Everybody that leaves our unit gets that. We work with Care Hawai'i, all of the community partners, NAMI, everybody out there. And really, we could not do what we do on the inpatient unit without these different services set up in the community. It really helps us to be able to get people in, help treat them, and help push them out with services. Without those supporting services, they'd be right back. I can tell you, when I started at Single Medical Center, we come in and we be full, and we probably have 2-3 holds in the ER. In August of this year, our average daily census was 3. I don't think we've solved our problems, but I think with everyone in the community, with all the community partners, all the things that have been put into place, I think collectively it's starting to make an impact on what's available. When COVID hit, everybody was thrown into telehealth, whether you wanted to see a doctor in person or not, didn't have that option. Now, on the inpatient services, we use telehealth on the weekend. Our patients see a doc through the video. And at first I was like, yeah, I don't know how that's gonna work with somebody who's doing psychotic. But it works. Everybody's used to it. So, for us, it's efficient, it's cost effective at times, but for the most part, being able to change our practice, COVID really threw us into that, whether we want to change or not, and we have to do it. But I'm really, really surprised and just amazed. Working with Tim on the mental health summit, we met with HPD and was able to talk through this mental health emergency worker. Okay? So for those of you who don't know, we have a pretty robust system to get somebody into the hospital. And it starts off with an MH1. And that MH1 allows police officers to bring someone in. And because you're violating someone's right without it, they have to go through this legal process. So what they have to do, back in 2020, the laws changed where it required them to get that. If they were going to bring somebody in, you had to call someone, and it was either an LCSW or an APRN that is now based out of Queens, in order to say, yes, this is a mental health crisis, go ahead and take them to the nearest emergency, or, no, I'm sorry, that's criminal, take them to jail. And so, for a long time, we were running, even though the law said you have to do it, nobody was doing it. And Oahu started to pick up, and then just this year in January, HPD jumped on, and we're now using that process, and it really helps in keeping individuals who don't belong in the ED going to jail, or being helped by crisis mobile outreach workers. The HPD will now call and vet that call, and if they feel like it can be addressed by other services, they'll do it. If they feel like the patient needs to come in, that will be recommended, or if they feel like they need to go to jail, they'll go to jail. But it really helps with not overburdening our ED. And I don't know if many of you do know, but medical ED is the second busiest ED in the state next to us. So that should give you the amount of volume that we see. And we're a very, very, there's many times we come in and we've got patients lined up in the ED. And it's very stressful on workers, on the ED staff, on the acute level, but they do a very good job at doing the best with trying to get everybody in space. Not only that, we have an aging population in here, and there's no resources. There are limited resources to long-term care. Now you put behavioral health in there, someone who has had mental health issues all their life from their aging. They won't take them in the long term because of their behaviors. So that's something else that we need to really look at and see how we can best serve our elderly population that's suffering from behavioral health. We work very closely with the AG's office, who I was just notified that they will be working with helping to process the assisted community treatment program ACTs. And that's going to be a game changer where if people are in the community and they're high utilizers of police being having to be called out, or high utilizers of the ED, or being admitted to non-compliance with their meds, we can now do force meds in the community, the management. So that'll be a game changer, even for our 704, or what I call, people who are who break the law and their orders to treatment. Now that we have the ACP, that much helps them stop committing crime.
You want to mention the LEIs?
Yeah, that's another thing. LAI started way back in the day. Now it's like the newest thing. We try to get everybody on LAIs. The thing with
LAI is a long-acting injectable.
Yes.
So it's a medication, rather than taking your pill once or twice a day, an injection that can last 30 days, up to 9 weeks.
Yeah. And the thing with that is why it works so well is when individuals start to feel better, but they're doing it. And so this injectable really helps. No more daily pills. No more, oh, you missed it yesterday, you missed it last week. And it's actually, some of them are very forgiving, that even if they go past that time frame, they can still get right back on. So it's wonderful. But, I'm so fortunate to work for Hilo Benioff Medical Center. Our leadership is very, very in tune and committed to taking care of our community. And they recognize the need for behavioral health services. And that's exciting for us, not only as a healthcare worker, but also somebody who lives in the community. So I'm happy to be here. Thank you, Tim, for inviting me.
Yay.
You all hear me? Yeah. All right, I'm going to stand up because I'm the short one. I'm Susan McGovern, and the only initials after my name are NAMI, and that stands for the National Alliance on Mental Illness, or NAMI. I'm a volunteer for NAMI. I've been involved, and we have some of our NAMI team out there, right out there. We're honored to be here today, and we just love working with all the pros, and with Tim. Tim's been so workable, easy to work with, always considering NAMI. We're the families, we're the ones with the mental health conditions, we're the ones that need help. So we work with everyone in the community. And NAMI actually has 4 very important pillars. And I'm going to teach them to you right now. The 4 pillars of NAMI. Number 1, support. NAMI is the largest grassroots mental health organization in our country. We have over 600 affiliates, just affiliates alone, and we are the Big Island affiliate. We have a state office in Oahu in Honolulu, and we have an affiliate on Hawai'i, Oahu, Maui, and Mokuokeawe, our island. So these 4 pillars of NAMI go through support, and that's what we provide. A lot of support for the families, for the people who need the help, because we're doing it 24/7, not the 23:59, but 24/7. We're there when the offices are closed. We're there when you have to leave an answering machine. We're there. So we have support groups, which occur on just about every day of the week. You can look under the NAMIHawaii.org website. We've got a full list of support groups on every island. Some of them are in person, many of them are Zoom. So you just would not believe the number of people that need a support group. And they will come from Australia, from England, from Japan, from the mainland. So we get them. So we're there for everyone. And everything that NAMI does is free. all the services we provide are here, because we're all volunteers. But besides support groups, we also have educational programs. We have a very important signature program called Family to Family. Likewise, we have peer to peer. So we work with family members, we work with our peers as well. And we also have the second pillar is education. The first one was support, we support, but we also build education. We give classes, we go and give presentations. We also have advocacy. So we just heard from our representative in Congress, Joe Tokuda. We're the ones also knocking on the doors at the Capitol building and saying, remember that law that was passed in 1996? We need to work on that. So advocacy is a big one of the pillars. And our fourth pillar is public awareness. And here's where I have a commercial time, because public awareness includes once a year, NAMI sponsoring a walk. And it's called NAMI Walks. Saturday, October 12th, in just 2 days. And you are not busy on Saturday. We invite you all to come and join us. And I actually have some flyers here. So I'm going to put them, make them available. It's called our NAMI Walks event. It will be at the Wailoa State Park Pavilion number 3. We'll gather there and we'll have some music and some entertainment and some snacks and things, and then we'll have a walk. And what are we walking for? To raise awareness and show our support for mental health in our community. So we're very, very pleased about that. And I think my 3 minutes are up.
You did really well.
Nonprofit community foundations and also part of some nonprofit organizations as well as some, for-profit organizations as well. But I'm not going to get into my work, side of me, because that's really not the reason why I'm here. Why I'm here is because integration is such an important part of health for all of us. Right? And it's hard to detach who you are based on mental illness, physical health, and based on your dietary needs, based on your spiritual health. It's easy for us in the West to detach all of that, right? You've got heart problems, go see your heart doctor. You've got a lung problem, go see your pulmonologist. You've got a mental health problem, go see the psychiatrist, go see your psychologist. And then as a primary care practice, we just want to treat everything, but we don't want to touch it. Just want to manage it. So, for me, that has been the biggest struggle that I've had. I see behavioral health, example of behavioral health, and I've been in behavioral health for over 20 years now. That was my college, assignment. That's what I majored in behavioral health. And what I realized is that behavioral health is kind of this Western religion that was created to understand things that we just didn't want to accept from a traditional standpoint, right? So, think of how many of us go to church. How many of us believe in God? How many of us believe in the spiritual being? How many of us believe that rocks have spirits? How many of us, look at the ocean, stare at the sunrise, believe that's a natural form of healing for us, right? But then when it comes to mental health, when it comes to health, you just kind of want to shut that part of a person out and say, like, take your medications, go follow your case manager, follow your service plan, make sure that you go to see your psychiatrist, and just kind of this, cutting this standard way of preaching this religion of behavioral health to our clients and to ourselves, right? So when you try to integrate that with with physical health, then you have this religion of physical health about how we believe, people should take care of themselves physically and, take care of their medical issues. But I always run into this fact that we just forget and we neglect the traditional part of who we are. Right? We all grew up with our own traditional thinking. We all grew up understanding that there are certain things that we could do to take care of ourselves that Western medicine or medical medicine, psychiatric medicine doesn't do for us. Right? It's easy for me to say, here, take this pill. It'll make the voices go away. But what else is it going to do to me? It's going to make me fat. It's going to make me lazy. It's going to make me lethargic. It's going to make me want to not do anything, unmotivated. Right? Or it could help me get a job, or it could help me, be more productive. I don't know. I don't know that. But we don't address any of those things. We just, other than just push, treatment onto folks. So my whole thing is that until we can look at traditional healing and look at a person holistically, mind, body, spirit, right? Kua aina, na'au, everything. If you can look at a person for all they are, and address those traditional parts of who they are and respect that, and give traditional healing the same value that we do Western healing and Western religion of behavioral health and medication, then we really are going to lose sight of a lot of the immigrant populations that come to the right? And what I see is that a lot of the Micronesian community, a lot of the Polynesian community, a lot of the, now in Kona, we have a lot of Spanish, Mexican communities that are coming here with their religion, with their understanding, with their cultural practices, and yet we want to force our Western behavioral health religion onto them. So, and I use the word religion because to me it is, we believe so wholeheartedly. I did too for a long time, believe so wholeheartedly in this like Western model of like understanding behavioral health from the side of like, treatment, assessment, treatment, diagnosis, medications. This is it. And what I forget is that sometimes people don't believe that. Sometimes people come in and they don't want to hear about it. They want to talk about what works for them. Right? We're so confounded into what we were taught in school as professionals, to how we're supposed to prescribe, how we're supposed to treat, how we're supposed to act, and what we can and cannot talk about. So my whole thing is that, that disconnection is what ends up happening is we disconnect ourselves from our clients, from our members, from our consumers, patients, whatever we want to call it, like people nowadays. But if we can somehow bring that back in and, and I know it's very hard for insurances, I know it's very hard for practices, very hard for providers to understand that from that level, and to how to incorporate that into, or integrate that actually, into mental health and behavioral health services and also physical health, because the funding isn't there. A lot of times what we see is tokenism, right? We see, we'll just bring a Hawaiian practitioner and then they can sit on there and then we have a cultural practitioner, they could teach hula without really an understanding of like, what the fuck does that mean? Yeah, we have somebody who's gonna teach hula, but what does that mean? Like we have somebody who's gonna teach Ho'oponopono, but what does that mean? Like, are we doing it because that's just what we think we're supposed to do, and it has no meaning until the rest of that person's treatment in their life? Or are we doing it because we're trying to integrate that as a part of the healing process for this person? So, sorry, I didn't mean to use the F word.
I'm sure they can bleep it out.
I'm allowed, I had my one, I put the quarter in the jar. Yeah. So I was recently at the Workforce Summit in Honolulu, and I got the chance to sit with the Waianae Coast Comprehensive folks. And I don't know if you guys know Makani Tabora, but he's one of the cultural practitioners over there. And he said one of the most profound things. Sorry, it's getting really emotional. He said, Western medicine, somebody comes to you and they're high, they're loaded and everything. As a professional, like, what's our response? You need to go home, get sober. We need to go put you in a treatment unit, or you need to go home and I can't do anything with you right now. That's the wrong response. No, he said, you come sit next to me. I'm going to feed you. I'm going to ruin your high. I'm going to make you regret coming here because I don't ever want to see you coming here again for this reason. So you bring that person in. And to me, that was like, that's profound. Like that's how you treat people. You don't turn people away, but it's hard because as a professional, like I know for myself, if somebody came in and they're high, automatically it's like, no, you need to go. Sorry, I cannot help you right now because you're high. You're not going to understand what we're talking about. But at the same time, from a traditional point of view, I think back to my parents when cousin of mine used to come to the house, high, drunk. The mom would bring him in, feed him, clothe him, bathe him, give him a place to stay. And I know that's not what we do as professionals, but we can do that to some level as professionals. So integration for me is really just not, it's about bringing behavioral health and physical health together, but then how do we look at the person holistically? How do we integrate that person's beliefs, our beliefs, and look at other things alternatively that can treat this person and help them become more productive as in society. So, okay, I'll stop. Thank you.
Last but not least, Dr. May is here, and Western medicine perhaps, but they're coming around or going back or they're figuring it out. And I'm just so thankful that you're part of this panel. And with your introduction, we can move into this part of the presentation and keep going. So thank you.
Sounds good. Thank you. Can everyone hear me okay? Ooh, that's loud. So I was blessed with the voice volume of a librarian. And so if you guys can't hear me at any point, just wave and I will speak more loudly. Feels like yelling. So I really love a behavioral health space. I can see on all of your faces how much you care about the topic that we're here to discuss. And I'm a natural listener. I'm not a natural talker. And so I kind of just want to hear all of your stories and talk to you today. But somehow Tim kind of persuaded me to do a lot of talking today. So I'm going to take a little bit of time to talk about who I am, what Hawaii Island Community Health Center is, and talk about what integrated behavioral health looks like when it's really put into practice. So my name's Catherine. I'm a clinical psychologist. I've been on Hawaii Island for 14 years. I'm from London originally. I'm a city girl. So living in rural Hawaii is a big change for me. But I love it here. And I started my career here working for the Big Island Substance Abuse Council. And it was just such a wonderful introduction to healthcare in the community. And I worked there for many years. And then in 2016, I shifted and I moved to Hawaii Island Community Health Center. Back then it was West Hawaii Community Health Center. And I was trained within the National Health Service in the UK. And so that's kind of a free healthcare program. They provided healthcare for me as a child. I was pretty unwell. And so I feel very, very grateful to the NHS for the care that it provided for me. I was in hospital a lot as a young child. And so I feel forever grateful to the NHS for the care that was provided to me. They also trained me for free. And so every time I do a presentation, I just like to acknowledge the NHS for what they did to get me here today.
National healthcare and national education.
Yeah. Who'd have thunk it? I know. I even got paid time off and a retirement plan as a student. So it can work. So today I'm here to talk a little bit about Hawaii Island Community Health Center. I've said I've got nothing to disclose, no conflicts to disclose, other than I like to make friends. So my email address has been up here the whole time. If you want to connect with me afterwards, feel free to reach out. I'll put it up again at the end. If you haven't had a chance to write it down, you will get a chance. It's long. So just kind of a roadmap for today. I'm just going to do an introduction to the health center, an introduction to integrated behavioral health and how we implement this at the health center. I'm going to use a brief case study to kind of show how this works. And then I'm going to talk about some of the challenges and next steps of integration at the health center. So a little bit about Hawaii Island Community Health Center. So we're a federally qualified health center. We provide healthcare to individuals regardless of their ability to pay. And so for me, as someone who came from the NHS system where healthcare was really seen as a human right, the FQHC arena really feels like a very natural fit for me. And I really believe in the mission of the health center. I'm not going to go through the mission, vision, and values, but I just wanted to pull out, hopefully you can see in green, that integrated care is really part of our mission. And I think that shows how important it is to us at the health center. So I'm not going to go into all of our services. I could probably speak for about 3 hours about everything that we do. But I think when people think of Hawaii Island Community Health Center, they think of primary care. But we offer a wonderful selection of services, including dental, our school-based services. And this is actually Dr. Stephen Pine, who's sitting in the room back there. So you can all make him feel awkward. Yeah, so we got a big team here today, but and all of the photos of our staff in this presentation. So we really are a lot more than just primary care. And so today I'll be focusing a bit on behavioral health, but if you have any questions about these other services, school-based health centers are particularly exciting to me, please let me know. So for those of you who aren't familiar, Hawaii Island Community Health Center is a relatively young organization. We've been a combined organization for 2 years now. We are the result of a merger between West Hawaii Community Health Center and Bay Clinic back in July. And so we are now one of the largest FQHCs in the state of Hawaii. We service about 37,000 patients and we have a staff of over 450. So what is integrated behavioral health? The area that I'm so passionate about. So integrated behavioral health basically brings behavioral health into the primary care setting. And it delivers evidence-based practices within a setting where the patients who need it the most are located. We've all heard about kind of the mental health crisis, right? I think the COVID pandemic really shone a light on this, but these statistics, are kind of around the time of COVID. We know that about 1 in 5 adults in America has a mental health diagnosis. About 5.5% of individuals, adults, have a severe mental illness. So we know that's kind of the case nationally. If we think about more locally, we know that individuals who kind of self-report that they have 2 or more races, the incidence of mental health increases, and that number goes up to 1 in 3. We also know that Native Hawaiians and other Pacific Islanders are 3 times less likely to have access to mental health services. So if we think about Hawaii Island, it's looking like we have a much higher incidence of mental health, and it's really hard to access it. So why primary care for mental health needs? And I'm going to kind of lead this slide up for a little bit because I really think it shows how important integrated behavioral health is in a primary care setting. So as many as 70% of primary care visits have an underlying mental health component, right? That high blood pressure that someone's coming in for, that unmanaged diabetes, quite often there's an underlying behavioral health component that's kind of contributing to it. 70% of behavioral health medications are prescribed in primary care, not in specialty care. This third statistic, I think, is the most kind of profound, which is that 50% of people who die by suicide had been in to see their PCP within the last 30 days. Think about that. Excuse my teams. That number actually increases to 80% if we look at the last 12 months. So what does this tell us? It tells us that people with mental health concerns and people who are in crisis are going to primary care to receive their care. And we have to bring behavioral health into that arena to make sure that we're saving people's lives. So how does integrated care respond? So integrated behavioral health brings behavioral health services into the primary care setting where it's needed most, where the patients are showing up. It allows for early identification and screening of behavioral health problems. It allows for collaboration and support for medical staff, for PSR staff, for nursing, for MAs. It allows that additional layer of support to be brought into the clinic. And most importantly, it reduces the stigma around accessing behavioral health services, right? It reduces that barrier that we talked about a few slides ago. So what does integrated care look like? So this is kind of the spectrum of integration. You can look this slide up. It's, I think, in the references at the end. But really, we go from this level 1, which is minimal collaboration. And this is kind of your traditional separate doctor's office, separate behavioral health provider working independently. They may have never really met in person. They may not know much about each other. They're using different electronic health record systems. They might communicate occasionally. Right? Usually it's driven by provider need rather than patient need. I want to find something out from you. And they have really, really little sort of sense of what's happening in the other person's arena. At the opposite end of this spectrum is kind of where we strive to be at Hawaii Island Community Health Center. And this is level 6. So this is full collaboration. And so what does this look like? So it looks like behavioral health being co-located on the clinic floor. I'm a practicing clinician for the health center, and the majority of the time that I see patients is actually out in the clinic. I'm in exam rooms. I'm going into the space where they're being seen. It's very different from traditional psychotherapy. I'm not protective of my space. People come and knock on my door all the time, right? We're collaborating. We're working alongside the medical providers. We're working within the same EHR. My notes are part of the patient's health record. They have access to those notes. I tell them at the end of every appointment, you can read what I write. None of this siloed behavioral health specialty. We keep what we do a secret. This is your healthcare. Your care team has the right to access it, and you are part of that care team. So we work as a team to support the patient. The way that I describe it is I kind of say that we're like a triangle, where the patient is at the top of the triangle, the PCP is at one other corner, and the behavioral health, provider is at the other corner. So we work together to support the patient, and patient-centered care is really the direction that we're going. We have formal and informal communication channels and pathways. So we can have formal meetings, we do that, we get together, but we also have informal chats. We have everyone's cell phone numbers. We have Teams messaging. So we can communicate at this really rapid rate. You know, if we have any private practitioners in the room, think about the access to the information that you're lacking in your care of patients. I have access to patients' medication records, their lab records, right? Their hospital ED records. I have all of that information, and I can collaborate with that team in real time to provide, I think, excellent care for our patients. We have roles and cultures that blend and blur, and I think this is the most exciting piece about it, which is that because behavioral health is on the clinic floor, we're sharing information with everyone that we work with, from our front desk staff to our call center. We're doing training with those individuals, right? Our PCPs are doing behavioral health interventions. Our dental team are doing behavioral health interventions because we're working as a team, right? As a behavioral health provider, I'm also doing kind of more medical interventions like I would have anticipated. If a patient that I'm working with has run out of medications, I don't need to schedule them an appointment with a medical provider. I can just send a message to the nursing team, say, hey, can you check this prescription for me? And they will get to it, right? So we have these sort of very different roles from what we would typically think of as a behavioral health provider. But the result of that is that we really increase access and we expand care. So who is eligible for integrated care and how do they access it? So anyone who is a patient of the health center is eligible to receive behavioral health care through us. We have a saying that we ask everyone the same question. Every patient who's seen at every single appointment is screened for behavioral health sort of symptoms. We do the PHQ-2 and we do a question from the GAD-7. What happens if someone screens positive is then this triggers kind of a ripple effect of care. And so we're able to connect with patients. This is not the only way though. A patient can just call up and say, hey, I need to talk to someone today, right? They can come to front desk and they can say, I need to speak to someone. Their PCP may say, hey, you didn't answer any of these questions in a positive way, but I see that you're really distressed about something today. Can I set you up with an appointment? So there are multiple ways that patients can receive care with us. And we use an SBIRT model. So for those of you who aren't familiar, it's the screening, brief intervention, referral to treatment. So who provides care at the health center? We have two distinct roles in terms of who's providing care. We have a more traditional behavioral health provider. So that's the licensed clinician, psychiatry, psychologist, LCSW. And they're doing really that kind of like diagnostic, treatment, coping skills, those kind of things. We also have a really unique role, I think, which is the behavioral health patient navigator. And so these are kind of pre-licensed or unlicensed, very skilled sort of paraprofessionals, I guess you would say, who have experience with housing, food insecurity, drug treatment, alcohol treatment, and they support patients with these kind of additional wraparound services. So when you access behavioral health through our clinic, it's not just a licensed provider you're getting access to. It's this whole care team that have different skill sets and can support you. And so we have right now currently 16 behavioral health providers, licensed clinicians, and 10 behavioral health patient navigators, many of whom are on track to become licensed clinicians with us. Many of them are pre-licensed MSW students who are working to become clinicians, hopefully at our health center. So that idea of growing your own, it's much easier for us to recruit behavioral health patient navigators. And so we're really focusing our efforts there. And if anyone has any questions about this afterwards or is interested in work, you let me know. So what are the sort of appointments that we have? And I'm not going to go into all of these, but I'm going to highlight the top two, which I think are the most kind of unique to integrated care. The first is the same day warm handoff. So this is when a patient has come to the clinic for a medical appointment. And during the course of that visit, it's identified that they need to see behavioral health, either through some sort of screening or just kind of what they're reporting in the appointment. The way that we do this is we just introduce them. So it's called a warm handoff because we're literally doing a warm handshake from the PCP introducing the behavioral health provider. The reason this is so important is that the research shows us that when a patient meets an actual human being, they are much more likely to follow up with care than if we say, I'm going to refer you to someone, right? So if we think about that slide about who's accessing mental health treatment, this is a really nice way to ensure that patients meet the person that they may follow up with. It doesn't need to be a long appointment. We say just a meet and greet, just so that you know that I'm not a scary person, right? Dr. May, people come in and they say, I was expecting a short Asian lady, right? And they meet me. So getting to see who I am, what I look like, the sort of interaction, the way that my voice is, right? That's all information that they can use to say, hey, I want to come back and see this person, or find me someone else, which happens to. The other type of appointment that I think is unique is the behavioral health consult. And so this is an appointment where a patient sees the behavioral health provider and the PCP on the same day, kind of an overlapping appointment. And when this works best, I think, is when you see the behavioral health provider first, and then the behavioral health provider can kind of relay information to the PCP through a kind of brief consultation. And so it allows the PCP to step into that appointment with the patient with all of this wonderful kind of background information. And so it makes their appointment much more efficient. And the PCPs really find these appointments helpful. We then have the more kind of traditional follow-up type appointments too. We see patients predominantly in person, but we do offer MyChart appointments, telehealth appointments, and telephone and telehealth. We also have a support staff visit type for the behavioral health patient navigators. So let's look at an example of how this kind of works in real life. And this is a de-identified example. So this is the case of Malia, who's a 22-year-old single mother of a 1-year-old child. She comes to the health center for an appointment for birth control. So you see that kind of medical appointment, right? No seeming behavioral health concern. During the course of the appointment, she's screened using our screening tools, and it's identified that she's experiencing severe depression and anxiety with suicidal ideation. And so the PCP is able to request that same day appointment. A behavioral health provider comes in and is able to do kind of crisis stabilization with Malia, a brief assessment, identifying that she's most likely experiencing symptoms of PTSD, and is able to identify that she's experiencing some social determinants of health that are really exacerbating her symptoms. The behavioral health provider works with Malia and the PCP to establish a prescription for antidepressants, refers to the behavioral health patient navigator to get support with social determinants of health needs, right? And I think it's really important here to highlight that we're doing crisis stabilization here, right? How many medical providers, if a patient like this walks into your clinic, do you think the next step is the hospital, right? Malia is suicidal, I've got to get her to the hospital. Malia has a 1-year-old child. What happens to that child if Malia is admitted to the hospital, right? So same day warm handoffs to address crisis and stabilize someone with hope really keeps families together. It keeps patients out of the hospital setting, and it allows us to stabilize. So that's why that same day appointment is just so valuable. Following that initial appointment, Malia is scheduled for a 1-week follow-up with the behavioral health provider. In that appointment, we're assessing for Malia's kind of response to the antidepressants, right? We see that blurring of roles and responsibilities. The behavioral health provider, not the medical provider, is checking in. How are you responding to these meds, right? If Malia was reporting significant side effects, guess what I can do? I can get a medical provider in to see her. But I've been able to expand the care of the medical provider by doing that as a behavioral health provider. We see that Malia is responding well to medication. Symptoms are still pretty severe, but she's getting help with the social determinants of health needs. We're looking at some coping skills to help her get through. 2 weeks following the initial appointment, we do that behavioral health consult, right? That's with the medical provider and the behavioral health provider working as a team with Malia. We see she's much more stable, social determinants of health issues are being addressed. And so the PCP says, hey, Malia, I'm going to let you continue with the behavioral health provider. You can come back and see me if you need, but Malia will get ongoing care with behavioral health with the plan to refer eventually out to a community therapist for really focused therapy for trauma. So hopefully that gives you kind of an example of how this works in the real world. So what are some of the benefits of integration? First of all, it works, right? We see it working every day. I think one of the real benefits to me is that behavioral health kind of gets disseminated to everyone in the clinic. And this was really exemplified to me. I had a patient about a year ago who came in to see me for an opioid use disorder. This was someone who was really chronically unwell with opioid use. And so this person, when she finally saw me in the exam room, had interacted with 5 or more staff members from the call center, PSR, MA to room her, nurse, medical provider. And this patient said to me, this is the only place that I've ever received care where I did not experience any stigma around having an opioid use disorder from every person that I interacted with. And I think that really exemplifies the benefit of integrated behavioral health, that it's not just about the patient. It's great that it's there for the patient. It's not just about the medical providers. It's about everyone who interacts with the patients, that we recognize that these patients are our patients. They are us, right? And so I think that's just a really valuable piece. I think it also allows us to really run a trauma-informed health center, that we're there not only for our patients, but also for our staff members. If we have a traumatic event that happens, guess who's there to debrief and de-escalate afterwards? So in terms of staff retention and just kind of mental health, we're able to support our staff with their own suicidality, their own experience of domestic violence, right? All of these things happen for our staff too. And so behavioral health being available and part of the team just really makes such a difference, I think. I'm going to have to say this, but we also won an award for it. We are a national quality leader. So yay for us. But most importantly, like I said, it normalizes the need for behavioral health support in the patients that need it the most, or for the patients, I should say. What are the challenges? And this is my last slide, so I can stop talking. So what are the challenges? Most behavioral health providers are not trained in this model. I know I wasn't, right? As a behavioral health provider, my day often looks like 12 patients on my schedule. For most therapists, that just sounds like a nightmare, right? But it's a quick pace, rapid intervention. We're working alongside medical. And so we have to work with our behavioral health providers to kind of retrain them a little bit. Ideally, we run in an expert model, right? We do screening, brief intervention, and referral out to specialist care. As an FQHC, the majority of our patients are Medicaid patients, and it is really, really challenging to find a private practitioner that is accepting Medicaid patients. And so we end up kind of straddling 2 worlds, that we do this integrated model, but we also end up kind of holding our patients for longer than we really should in a traditional model, because there's no one else to refer them to. So this is my ask for any private practitioners out here. Please consider accepting just a small percentage of Medicaid patients. Your FQHC brothers and sisters would really appreciate it. And then last point is that sometimes the need is bigger than our capacity to help, right? Our numbers for patients really reflect kind of the statistics earlier. About 1 in 3 of our patients has a mental health diagnosis, right? You saw earlier we have 16 behavioral health providers. So there's some interesting math going on there in terms of patient panels, right? And so we're really looking at how we can expand our reach to patients. I think what happens for us is that the majority of our patients that we end up working with really are the more severely mentally unwell. And so I think this leaves a lot of space for patients who maybe are that like more at-risk patient population. So we're looking at increasing our capacity for groups. We're looking at kind of ways that we can move individuals up and down the step care model. And so more to come. This is my little passion project. And so hopefully we'll see more of this in the future. So I will stop talking now. Thank you so much for your attention.
Is it okay with you if we just get a few questions? If you can let us know who your question is for, and we'll try to respond as best we can.
My question is for the panel. So first of all, thank you for what you do. It's hard work, but difficult people. And I think we all understand that. So how do we help those that don't want help, that aren't in structured situations, that aren't in your offices, that don't make appointments or don't keep appointments? And basically the people that we are seeing and interacting that are on the streets that have behavioral health issues?
Yes, you're all looking at me. Yes, so I'm just gonna go back to a statement I made earlier about how we build rapport. We have an incredible team, and it involves our outreach team, our shelter staff, our newly formed integrated care hub staff, where we're focused on the medical respite, both medical and mental health. And we also have now, we're blessed to have a therapist who goes out into the street. We also have our Psych Street Medicine program with Dr. Chad Koyanagi, who is identifying and working with individuals on the street. So it's about building trust. And I know that maybe sounds cliche, and we say it all the time. The thing is, you have to have the resources and the capability to go out to meet people who seem to be resistant to care. And really what it is that we need to raise an awareness. So what seems to be a resistance or a refusal of care is really, I don't know that I need care. I don't know that I want care. I have my priorities and it is not care. So, being able to understand that and come from that angle, and then bring in a team who understands that and says, okay, so you don't want to talk to me today. Oh, you're walking away from me. Okay, so I'll come, I'm going to be here next week, and then you show up, and you show up, and you show up. And after a while, you still may not get that, hey, I'm ready, dog, to go get that care. But they're not walking away anymore. Maybe they're willing to accept some of that care. We have an advantage of, you see a wound, wounds are an open door to connecting with somebody. I can take care of that visible thing that hurts you, that you see. And then you have conversations and you learn a lot. So it's a chip away thing. And there's no quick fix, and sometimes there's no fix at all. But I do want a quick story about one gentleman who schizophrenia, unmanaged, refusing medication. This was our approach. This was our approach. We had this amazing team who just kept connecting with him. It did take a major injury and a hospitalization to sort of get him to stay in one place. But once he did that, he was agreeable to a long-acting injectable. And by the way, that's not just psych meds, but I just had to throw that in there. So antipsychotic long-acting injectable. And he had family on the mainland, specifically daughters, who tried to stay in touch with him. He talked very fondly of them, but it was too difficult for him to live with this family. But once he got on the medication, he responded favorably to it. He started to have more and more lucid moments. And when he had this accident, it just sort of it coalesced all of this, like, wow, life is short. Wow, bad things happen to good people. Wow, we can make this work. And after years and years of distress and disconnect and escalated behavior and in and out of the jail and in and out of the hospital, he reunited with his daughters on the mainland. And so it can happen. It took years, right? But it can happen.
We have a lot of positive that happens. I would implore you all to expand the capacity, figure it out in West Hawaii. We only have about 100 chronic homeless that have these issues. And the problems are huge. And if we don't fix it, they're dying. And from a humanity standpoint, they're dying on the streets. And so they need help. And so collectively, we all have to help them.
I think going back to those core of having someone to call, someone to respond, someplace to go, and then that ongoing support. And that someplace is not one place, it's multiple places. Whether it's the psych unit, or whether it's a NAMI support group, whether it's a living room drop-in model, whether it's a shelter, whether it's an outreach team, a mobile unit, we have to be creative and know that even those 100 individuals are individuals and have individual life stories and pathways into wellness. So yeah, resources, staff. definitely. Yes.
Hello, my question is for the panel. I'm curious how you think intergenerational traumas and needs can be identified, because usually if one person, an individual in a family is impacted or affected, more likely than not, younger generations are also feeling that level of trauma. So what, if anything, are your various programs doing to help to identify and then, refer or address those concerns that you identified?
Yeah, great question. Really complex question too. I might not be able to answer all of it, but I think moving upstream is a really important piece. So if we can work with youth prior to problems, that we can really help them be resilient. And the way that we're doing that at our health center is by the implementation of school-based health centers. So we're bringing primary care to the school base where students are being seen and where they already are. Right. We initially tried to work on a program where we took referrals from the school. And what we found was that kids didn't come to the appointments that we set up for them at the health center. And the reason for that was that their parents were working, couldn't bring them. And so by bringing healthcare into the schools where the students already are, I think we really work to kind of be a protective factor for these kids and get them at a time kind of before the problems become really serious.
And part of like integration is also, there's the saying that there's no wrong door, right? So there shouldn't ever be, if you see an opportunity to step in and address it before it becomes a severe, persistent mental illness, if you have that opportunity, that's where you step in. There shouldn't be, I go back to that no wrong door approach, because that's really the entrance way into bringing people or someone into care and being able to address those things. I think the other part of it is also teaching, how do you teach staff about that intergenerational trauma? How do you teach staff who are actually a part of that system as well, so that they know how to separate their trauma from somebody else's trauma, and even look at themselves in that process, so that they can understand and relate to the person that they're working with. So, yeah, it's a very complicated answer, but yeah,
Rodney, I think of the cultural disconnect trauma as well, talk about multi-generational, right? And so as you described earlier, that the healing of connecting back to a core self of our practices.
Yeah, and I mean, it's easy to dismiss, and I am guilty of this as well. I just, they don't understand our way of method of treating them, but we forget like what the West has done to a lot of native populations, decimated generations of beliefs, and culture, colonization, and just creating this institutional racism that lives within, different cultures. And then we don't realize that when we go to treat somebody, and then when they don't want our help, they don't want, us to work with them, it's because we just aren't educated ourselves about what we represent. Even though, even myself, being Polynesian, I represent a system that has systematically oppressed folks. So when I come in, like we said, with this behavioral health religion that, I know how to help you, it's almost like I'm coming in again and creating more trauma. So yeah, I think, just we really got to be very careful and tread lightly on the way that we represent. And even just going back to the question earlier about what we do with folks who don't want your help. Part of our job really, as professionals, we're salespeople too. Like if we don't have the product that they want, what else can we bring to them? If I'm bringing you donuts and you want oranges, and I keep bringing you donuts, of course you're not going to want that. So it's like, how do we change our approach? How do we relook at what we're doing instead of blaming that person and saying like, well, when you're ready, you know how to reach me. It's that there shouldn't ever be a wrong door.
When we're talking about early intervention and early identification, as a community, we can all work on raising awareness and taking away the stigma. Because I do think that if people feel comfortable and safe in going to a professional, so many times I'm looking at situations in which I'm recommending What is the family thinking? Who are the support systems around this individual? Are they willing to come forward and work with a team to support someone in distress? And when a family isn't sure what to do, isn't sure what they're looking at, do they know where they can go and what resources they have? So.
I'm looking at Kathy. Because so much of this kind of conversation is exactly what we all deal with, especially in our NAMI support groups. Every single time. Lori, Kathy, Sarah, Tom, that's what we hear, isn't it, in the support group? My son, my daughter, my husband, my sister, my brother, and they won't listen to me. And they need this, and they need this, and how do I fix it? How do I fix it? It's a very complicated thing, but we also have to understand they are people. So our NAMI approach is love. It's about love. Love them, accept them, know who they are. Part of the help is, hey, I know you're suffering, I'm suffering too. How about we both work on this together? And work on it as a family or as a team. So,
NAMI walk.
come and join us.
Oh, look, it's on Saturday. Thank you. We have about 5 minutes left. We'll take one more question and then we'll go.
For the nurse manager, thank you for serving the size of the metro. I think that's challenging. So what happens with the teens that are suicidal? Are those beds only for adults, or are they sent to separate by the hospital and have a nurse assigned to watch them?
That's a very good point. Thank you for bringing that up. You know, our youth is desperately underserved. We have no place. What is most upsetting about this is that there are times where the adolescents, they have to sit in the ED and they have to wait to be transported
Where?
to Oahu, to Kahimuhawa. There is no inpatient service here. I don't know what we can do as a community, but we need something. We need something for them. What happens is, at a time of crisis, we end up separating them from their families. And that's not how we treat them. Not only that, these kids are sitting in the ED. Remember I told you Hilo is the second busiest ED. Well, we don't have a lot of room in our ED, and unfortunately, there are times where they are watching a lot of trauma victims come in. So on top of going through their own internal mental health crisis, they're now watching family members die, and they can hear it, and so.
So you cut off from
18, age of 18.
A growth area, a need area, an emergency area, perhaps.
Good question about the bed. So it's nowhere in that bed, you know, and there's one pharmacist able to.
We don't have beds in Kona. So sometimes a lot of times they're holding the ER, and then if there's no beds in Oahu, then they get discharged. Maybe they've been there for like a day or two, or it's really an issue.
So I'm just going to honor our time, and we've got about less than 4 minutes left. And I want to give our panelists an opportunity just to kind of give any final thoughts. If you needed a prompt question, it would be, are you hopeful for the future of behavioral health? Why or why not? And any other closing thoughts that you might want to give. We'll start now.
Because I'm nodding my head.
Yeah.
I just know how far we've come. I see it every day in the patients with whom I work. It's visible, it's tangible, it's measurable. And so I'm extraordinarily hopeful. But like Susan, throw money, throw money, throw money. Because it allows us to hire staff, to reinforce the resources that we can provide. But I also, our community partners, they're invaluable, they're precious, and we couldn't do this alone in a silo. We all are getting to know each other, strengthening our relationships, And that is also why I have so much hope, because of people that you see before you who open their doors and pick up their phones and say, not, well, that's not what I do, but how can I help?
And I am thankful, and I'm thankful that we have things like these that bring us all together, people that are truly invested in making behavioral health more accessible to our community. So with that, I say, yes, I'm very hopeful, but we have a lot of work to do, especially with the adolescent population and bringing something here for them. But thank you to all of you, not just us as panelists, but all of you that help us together collectively try to make a better community that it has behavioral health services. There's such a great need, and we have a lot of work to do ahead of us. So thank you for your investment.
I'll say very quickly, NAMI always believes in two things. Number one, you are not alone. And number two, we must always have hope.
Yes, I'm very hopeful as well. And I just think about, when I first started working in HIV in 1995, harm reduction was a brand new term, and now it's everywhere. Everyone knows what harm reduction is. It was so controversial in 95. Now it's not even a thought. We incorporate harm reduction into what we do on a daily basis, our practice. And so when I first heard about integrated behavioral health was probably about 10 years ago, in 2014. And so now that we're still talking about it 10 years later, it's going to go in that direction where it's going to become a part of our vocabulary, part of our life, and a part of just who we are. So I'm hopeful.
I'm a psychologist, so my job is to have hope for the hopeless. I think if there's one thing that COVID showed us is that if we focus our efforts in an area as healthcare workers, we can have amazing results. And I think that mental health is kind of a new focus area that has not had the attention that it's deserved for a long time, and it does now. So I am very hopeful for the future. Money is going to make a difference. But we as a community have done so much with so little. And when we work together, we really are able to produce wonderful changes. So a little bit of cash injected into that, and I think we'll go a really long way.
Shout out to legislators. Legislators, family members, thank you.
And I'd like to say I walked in here because of all the experience we've had today, elevated, but listening to you all, I'm up there. I'm a short man, but I'm up there. Thank you very much. You're wonderful.
Yeah.
You surely are.
Rob, you earned your cookie.
It is very nice for the opening one.
I just want to say that on October 28th, there is a workshop in Hilo called Healing Together, Unpacking Mental Health Stigma. 18, with compassion and awareness. There are flyers in the back there for those of you that are on the Hilo side or you want to come over to Hilo on that day. That would be great. I am hopeful, and I'm hoping that you enjoyed this panel, that you were inspired, you learned some new things, but more importantly, that you feel that energy, that sense of urgency, that there's work to be done, and that we're not alone, we're hopeful, and that we can move forward and build these services for our community. So mahalo to you.